Thank you, Professor Azzolini. Ladies and gentlemen, esteemed guests, it's really an honor to be here with you today. I'd like to acknowledge my colleague and friend from Chicago, Professor and Chair Dr. Paul Chan. Next slide, please. Causes of pediatric blindness vary from and within countries for a variety of reasons. Congenital cataract is a primary cause of pediatric visual impairment in low-income countries. Next slide. Whereas retinopathy of prematurity prevails in middle-income countries. Next slide. The story of the deployment of telemedicine to bear on the management of retinopathy of prematurity is informative with regard to underserved and under-resourced countries, as the learnings are extrapolatable to other disciplines and other conditions. Technology, human resources, and data are all critical to achieve the desired goal. Next slide, please. Underlying successful initiative in this area are teamwork and collaboration for all of the work streams. Here's an image from one of the early classification groups taken 20 years ago in Canada. Next slide. And here's a composite of the telemedicine and teleinformatics team that Dr. Chan participates with today. Next slide, please. Retinopathy of prematurity, or ROP, is a scarring and potentially blinding disease that affects the smallest and sickest of premature infants. It was first described in 1942 and remains today, 80 years later, a globally impactful and challenging disease, particularly from a diagnostic perspective, as it takes years to acquire the appropriate clinical acumen. Next slide, please. And in fact, as was the case in 1942, every time a low to middle income country ascends to having more diffuse neonatal intensive care units and the availability of incubators, a wave of retinopathy of prematurity follows. Yet ROP is an eminently treatable disease. With timely and appropriate diagnosis, 99% of children are effectively managed. And that underscores the importance of surveillance, as an at-risk child will only do well if they can access the care pathway, and that requires diagnosis. Next slide, please. So by way of example, in Armenia in 1995, there was only one neonatal intensive care unit, and by 2010, they had 9. And a wave of retinopathy of prematurity followed. However, by virtue of telemedicine and teleeducation, next slide, please, with effective transfer of diagnostic and treatment skills, next slide, please, and ongoing telementoring, next slide, please, an important impact was made on minimizing the incidence of retinopathy, or the negative impact of retinopathy of prematurity on that population. Data from that study demonstrated that ROP was more common in the Armenian cohort, and that also children tended to be bigger at birth and still got the disease. If the criteria used in managing children in the United States had been applied, a significant number of children in Armenia would have gone blind. And that in turn underscores the importance of having on-site data analysis after the telemedicine construct is implemented. Next slide, please. So as you can see, it's a bit complicated. And the ideal, of course, is a global expert at every baby's bedside. Impractical, however, and it underscores the need for expertise extenders, and this cues the technological solutions. Some 20 years ago, my colleagues and I put together a smart, so-called smart diagnostic software that conveyed some of the critical diagnostic elements so that even a less experienced clinician could correctly diagnose the disease. The segue, of course, is to AI algorithms for direct output. Next slide, please. By way of example, 40 years ago, when the first classification system was created, the notion of plus disease, and this is the critical finding that determines if a child is going to be treated, this notion was binary. Normal, slide left, abnormal, slide right. Next slide, please. Now, this concept has developed to something being considerably more nuanced, with the vascular changes occurring, of course, in a continuum, and risk accruing across a continuum. Next slide, please. And so here is a cloud-based technology that combines clinical features with the diagnostic features of the retina, which is deployed in the treatment of ROP. Next slide, please. And there are examples of this deployment in Mongolia. Next. Nepal. Next. And more recently in India, where the AI component is being deployed in full. Next slide. So we have conversations about the digital divide. We, of course, need to go beyond the discussion of high-speed internet availability to all the telemedical infrastructural elements that are listed there and beyond. The need of an educational construct to convey experience, as well as gaining governmental support for on-the-ground issue management. Next slide. So AI will serve as a tool to bridge the implementation gap, but there are a variety of other aspects that are important. It needs to be device agnostic, for example, so that it can be deployed in full with consideration of local circumstances. Next slide, please. And importantly, we need to publish our findings when we have a successful deploy in the interest of gaining support and engendering sustainability. Next slide, please. So our learnings from deploying a teleassistance construct are that the requirements are those listed here, but really most importantly, the critical element is dedicated, perseverant people. There's a Helen Keller quote that resonates with the African proverb that was mentioned earlier, and that is, alone we can do so little, but together we can do so much. Thanks for your attention.